Welcome to Beyond Diagnosis, how physicians counsel patients on living well across specialties. In this podcast, we learn from the experts how all specialties practice preventive medicine. This is geared towards medical students who spend countless curricular hours learning the disease model and how to treat sick patients. This is a supplement to help us improve the lives of our patients by promoting optimal health and well-being, addressing the root causes of many conditions. My name is Michelle Omega, fourth-year medical student, hoping to one day be a family med doc. And today I have the honor of being with our expert in ophthalmology, Dr. Shields. Welcome, and thank you so much for being here.
Yes, thank you for inviting me to speak today. This is really exciting for me.
First, the formalities. Disclosure, this is for educational purposes only. Please see your doctor if you have any concerns about your health. Second, Dr. Shields, I just wanted to confirm verbal consent to publish this episode.
You have my consent.
Let's get right into our introduction. Dr. Carol Shields is Chief of the Ocular Oncology Service at Wills Eye Hospital and Professor of Ophthalmology at Thomas Jefferson University in Philadelphia. She completed her ophthalmology training at Wills Eye in 1987 and subsequently did fellowship training in ocular oncology, oculoplastic surgery, and ophthalmic pathology. She has authored or co-authored 12 textbooks, over 1,400 articles in major journals, over 300 textbook chapters, given over 700 lectureships, and has received many awards. Dr. Shields is a member of numerous ocular oncology, pathology, and retina societies and serves on the editorial board of several peer-reviewed journals. Each year, the Oncology Service manages approximately 500 patients with uveal melanoma, 120 patients with retinoblastoma, and numerous other intraocular, orbital, and conjunctival tumors from the United States and abroad. Dr. Shields, it is great to see you again. So for our viewers, Dr. Shields has a summer rotation, which I did a couple years ago, and I absolutely loved it. So thank you for the experience at clinic and the OR, doing chart reviews, publishing.
Thank you. Yeah. So we every year offer to the medical students a rotation on our service. And in general, we get maybe 20, sometimes 25 students who are interested in ophthalmology, and we host them.
To get started, my first question is, what are the main pillars of behaviors and habits that you counsel your patients about for health in your field in particular?
Yes. So for a healthy ophthalmic lifestyle, it's important to know what you're eating, to know your exposures, and to try to limit your time in the sun. So let me just clarify that. It has been clearly shown that smoking cigarettes exposures can lead to dry eye, cataract, age-related macular degeneration, and numerous skin cancers, including squamous cell carcinoma and basal cell carcinoma. So it's important to minimize exposure to cigarette smoke, not just firsthand smoke, but also second and third-hand smoke. The second thing is your nutrition. As an ophthalmologist, I always encourage patients to eat well, eat healthy, eat natural. The more green leafy vegetables and the more fish that you eat, the less is your risk for diabetes, but also the less is your risk for age-related macular degeneration. This has been clearly studied. Your intake can produce a risk for vision loss down when you're old because of some of the nutrients in some of the foods promote a risk for macular degeneration. So again, green leafy vegetables and a higher intake of fish. Now, I really encourage all my patients to avoid the sun. Sun is good when it provides the vitamin D and the happiness and fun you have out in the sun when you're playing with family or friends or whatever. But excessive sun exposure can lead to multiple different cancers of the eye. And I already mentioned some of the skin cancers, squamous cell carcinoma, basal cell carcinoma, and the worst, melanoma. But it's the same can happen on the surface of the eye. It's been clearly shown that excessive sun exposure can lead to squamous cell carcinoma on the conjunctiva. So I think it's important to avoid too much sun exposure. So that's basically very simple things, very practical and maybe a conscientious patient would already know these pointers.
Where do you think is the cutoff between getting that vitamin D exposure and not having any benefit?
I think in the old days when everyone would lay in the sun and put on the baby oil and try to get a dark suntan or even a sunburn, I think those days are over. I think most people nowadays are very smart about their sun exposure. I think wearing a hat, wearing sunglasses, I think a hat with wide brim is better than sunglasses. And I don't think anyone really knows what is the cutoff. I think a lot of it depends on your skin tone. There's 6 skin tones, Fitzpatrick skin tones. 1, 2, 3, 4, 5, 6, with 6 being darkest and 1 being lightest. And those people who have skin tone 1, 2, and 3 should probably limit their exposure to the sun maybe to, an hour a day. I'm just saying that, an hour approximately per day. Those who have a darker skin tone have more protection against skin cancers.
So, to what extent do modifiable risk factors play a role in some of the conditions you treat in your specialty? So, is there a potential for me to intervene early through patient education?
Absolutely. So every patient that I see with age-related macular degeneration, we put them on vitamins, vitamins that have the nutrients that they may have been missing from their general intake of food. I also tell them eat green leafy vegetables and don't smoke. But I mean, if they're 75 years old, the damage has already been done. So I tell them, in addition, tell your children and tell your children's children about good health. You know, no smoking and green leafy vegetables and more fish at a young age. So I think the younger you are, the better habits you have from a young age, the less likely you are to have age-related macular degeneration. Same thing with smoking. The less you're exposed to cigarette smoke, the more likely you're going to have good long-term health. It's funny with my kids, even with my own kids, and I have a big family. When my children were young, I always told my caregivers at home with the kids, and I did the same with my kids, don't let them eat potato chips and pretzels and all that. Put out vegetables and let them, if they need it, have a dip in ranch dressing or one of the dressings, just so they got used to eating vegetables. And my kids nowadays prefer vegetables to anything. They all have very good dietary intake. I think it is a parental responsibility to, train your children to eat well, train them when they're thirsty to drink water, not sweetened drinks. Part of the obesity problem in America is related to the intake of sweetened drinks. If you're thirsty, you go to Starbucks and get one of those sweet drinks. No, you drink just basic water.
When you're counseling these patients to make these changes, are there specific goals or strategies you have to help them actually put that into practice?
Yeah, so the majority of our patients, when we see them, and I deal with eye cancer. So when we see them, it's usually at an older age, in their maybe 60s, 70s, or 80s. And modifiable risk factors uh, can be incorporated at that age, but maybe their impact is not as great. Um, I generally try to modify their intake of nutrients, and I try to recommend modification of sun exposure, but I also tell them it's the next generation that you have to modify, and it's your grandchildren that you really need to modify their sun exposure and their cigarette smoke exposure. But I mean, we actually take a history on every patient who walks in our office. If they were an ever smoker, or when did they quit, or if they were a never smoker. And most of the time, we find out that most of our patients were previous smokers and quit in the 1980s or 1990s. So somehow somebody, convinced them to quit smoking. But smoking is a big risk factor. It's the second biggest risk factor for conjunctival squamous cell carcinoma. And I mean, that can be such a bad malignancy. It can involve the whole anterior segment of the eye, lead to blindness, and some people, we even have to remove the eye when they have really advanced squamous cell carcinoma. So it's pretty important. Luckily, nowadays we have some really good checkpoint inhibitor drugs that can focus on the squamous neoplastic cancers, but it doesn't always work. So we do have some drugs that can work. And, I just want to make one point. In our practice, we deal with a lot of uveal melanoma. That is melanoma inside the eye. So everyone's heard of melanoma on the skin, but the second most common site for melanoma is in the eye. Each year in the United States, there's about 3,000 patients who have uveal melanoma inside the eye. And we really don't know what causes it, but we do know that it occurs more often in light-skinned people. And there's a little suggestion that sun exposure can lead to that. No one has unequivocally proven that, but right now we're looking at, with many of the Jefferson medical students who are working in our office, we're looking at precise tumor location because we want to put a finger on, does uveal melanoma more often occur in sun-exposed areas? And the answer is yes, it does. So there was a study out of Harvard about 20 years ago where the conclusion in their abstract was uveal melanoma more often occurs in the macular region, and this means that it could be related to sun exposure. And no one ever reproved that. We usually don't believe something until we see two centers have shown the same results. Well, we're doing that. So we now have an article coming out where we have shown that uveal melanoma most often occurs in the posterior portion of the eye, and that could be a sign that it's related to sun exposure. And, just like being overweight doesn't just affect your joints. People who are overweight they're at higher risk for cancers. The body just can't, monitor the entire, system, and they are at higher risk for numerous cancers. Same with cigarette smoking. You're at risk for numerous cancers, not just lung cancer. And the other important thing about sun exposure is don't sun gaze. Every time an eclipse comes up, I get worried because all these fancy ways to look at an eclipse. But if you look at an eclipse the wrong way, you can burn the center of your vision. And then you can be without vision for life. I always tell our patients and my relatives, don't worry about looking at the eclipse. You can always look at a picture that someone took and you can stare at that. You're not going to get a central vision burn. But if you look at an eclipse and you look long enough, you're going to have this corona in the middle of your vision where you can't see, and it may not heal.
And then I was always curious about when an adult should start seeing an ophthalmologist if they haven't had an ophthalmic condition diagnosed before.
So I think that starts when you're very young. So when you're young, before you go, I would say there's no recommendations when the first examination by an ophthalmologist needs to be done. It's recommended that the pediatrician check the vision of a child at age 4 years. Why wait that long? Well, because kids don't give you a reliable visual acuity until about 4 years of age. Kids don't know their letters. They can't recognize a car or a telephone. So we usually wait till about 4 years of age. But to see an eye doctor, I think it's important when you're young, before you start into grade school. I think it's important to get an eye checkup by an ophthalmologist for a couple of reasons. Number one, to know what your visual acuity is. Number two, to know if you need glasses. If you're nearsighted, and there's an epidemic of nearsightedness nowadays across the entire world, really heavy duty in Asian countries, But now, since COVID, it's all over the world. And that's because everyone's looking at iPads this close, playing games, reading on iPads, and it stimulates you to become nearsighted. So there's an epidemic of nearsightedness, and nearsighted kids cannot see the board of their teacher. So I think it's important before you enter first grade that you get your eyes checked to make sure you don't need glasses so that you can see the board. So some children won't say, I can't see the board. They'll just misbehave in class, and it's because everything's blurred.
Mm-hmm.
And then it's highly recommended that everyone from age 40 on get a complete eye examination once a year.
Mm-hmm.
So the eye examination is to check for cataracts, to make sure there's no glaucoma, to make sure your glasses are okay, to make sure your retina's okay. There's a lot of things that go in to a single eye examination. And so that starts at age 40. And in our practice, I always remind our patients by, you know, by age 40, you should have, a routine annual examination. And it's important for our reason. We want to pick up pigmented spots in the back of the eye and follow them. And the pigmented spots that we pick up are choroidal nevi and freckles. And choroidal nevi and freckles are found in about 10% of Caucasians in America. I know that because we did a big study on that, where we looked at the NHANES database headquartered down at the CDC in Atlanta. And of all the thousands and thousands of people that they scanned, about 5 to 10% have a freckle in their eye. And it's most of the time freckles don't do anything bad, but 1% of freckles can eventually turn into melanoma. And melanoma, you got to catch it early, because if you catch it late, the patient's at risk for metastatic disease and death. If you catch it early, the patient can beat the melanoma. It reduces their rate of metastasis. So every millimeter melanoma gets thicker and thicker and thicker. It puts the patient at an increased rate of metastatic disease. So size matters with melanoma. Small is good, big is bad. And our practice here at Wills is, 80% judgment of choroidal nevi and choroidal melanoma. We see a lot of this on a day-to-day basis. And every Thursday when we go to the operating room, we're treating patients with melanoma from all over the US.
And now the big question is, what could robust health in your field look like for your patients? Like, what does it look like beyond the absence of disease, like exceptional, optimal ocular health? Because the idea is that an effort made in that positive direction is protective of falling in the other direction. Does this apply to ophthalmology, or is it more of a maintenance?
Right, Michelle, in a big way, this applies to ophthalmology. If I could talk to every high school student about how important it is to not smoke, to protect your ophthalmic health, to eat well, to preserve your vision. And I fast forward 50 years, we would see less squamous cell carcinoma. And if they all get their HPV vaccines, which they're supposed to do during their pediatric years, HPV is a known cause for squamous cell carcinoma, and smoking is a known cause. We would be reducing squamous cell carcinoma of the conjunctiva. And if they would avoid sunlight and be smart about their exposure to the sun and wear wide brim hats, I think we would see less skin cancers. We would need less surgery for skin cancers, less mutilating surgery, less, I think, uveal melanoma, because they would be protecting sun from reaching the back of their eye. I think we would see overall less age-related macular degeneration, less cataract, and less tumors. So yes, if I could talk to every high school student, because I do think it begins way back, when you're in your formative years, your teenage years, you start to form some of your nutritional ways and exposures. And if you can avoid some of the poor nutrition or bad exposures, you can protect your ocular health. So yes, people don't think the eyes are alive. They don't think the eyes can get cancer. They just think the eyes are not really alive. They're like fingernails. They're not alive. No, they're very alive. In order to see, you have to have real good blood flow to your eyes. And a lot of those bad habits impact blood flow and nutrition to the eyes, and vision slowly drops over time. Even simple things like what I mentioned about nearsightedness. There's been a recommendation by the American Academy of Pediatrics, 1 to 2 hours a day, iPad use, no more. Because you go more than that, you're stimulating nearsightedness. And your child is going to forever be in glasses. So, how you raise your children as a parent is really important. Good nutrition, reduce exposures, reduce iPad time. Back in the day before we had iPads, this myopia, nearsightedness, was still a problem because a lot of kids kept their nose in books. And even though reading books is a really good activity, you have to take breaks. And what has been recommended is if you're going to read books or you're going to use iPads a lot, you have to take a break and go outside and play. So now in China, what they do, because they have a pandemic of myopia, nearsightedness, what they do with the children in schools, in grade schools, is they give them frequent breaks and they let them go outside and play because you relax all of that accommodation of reading or iPad use, and then you look at the kickball that's way out in center field so that you relax your eyes, and that can reduce myopia. But there's even drugs that are now being used, atropine, one little drop of a small percentage of atropine to relax accommodation to reduce the amount of myopia. So just little things that people do can make a big difference. Remember, the eyes are alive. Everything you do has an impact on the eyes.
Mm-hmm. Thank you for shedding light that there's so much overlap between counseling on health overall and your ocular health, and what you do to your body as a whole can manifest in the eyes. It's really important for
Yeah.
us to
And
learn
Michelle, I'm
early.
going to say in your future, when you are a family medical doctor, I hope these podcasts are something that your patients are going to have access to. They can
Mm-hmm.
look up and talk about, how nutrition can affect your eye health so they can understand this. That's excellent.
Uh, Thank you so much. And some last questions. What are some of the barriers you've seen that hinder patients from achieving all of these pillars that we've mentioned to live well? Like diet, limiting exposure, smoking exposure, limiting
I
sunlight.
think there are societal barriers. People of low income tend to have less ability to purchase good foods and develop good nutritional habits. And there's a tendency to be more likely around people who smoke. So I think that's one barrier in society. I think there's no difference um, regarding gender or sex. I just think it's mostly an income thing. People of higher income tend to have much more concern about their nutrition and their good food intake. And I think if there's anything that is done, especially with like food pantries that deliver food to people of low income, they should be delivering high quality food so that low income people can have the same access to good nutrition.
That led right into my next question, which was when we do patient counseling, we're working on preventive medicine at an individual level. And did you have any advice for physicians on advocating for patients on the population level?
We deal with all different types of cancer, and we've done big studies on big population-based cancers. And I hope I'm answering your question correctly. You know, the older a patient is, the more likely they are to get a cancer of the eye. So I think it's important that the elderly get an eye examination. The more they're exposed to cigarette smoke. In fact, in one of our big studies where we looked at eyelid cancers, we found that it really depended on two things: age and smoking. And the only thing that was modifiable was the smoking. You can't modify your age. You can modify your smoking. We've done other big population-based studies on retinoblastoma, which is a childhood cancer that can lead to blindness and death in kids. And we did comparative analysis of high-income countries versus middle-income countries versus low-income countries. And we found something very, very revealing. Low-income countries, retinoblastoma is detected twice as old. That, like, the kids are detected much later, like a whole year later than they are in high-income countries like US and Canada. And their risk for metastatic disease and death is much higher than we see in the United States. And I think the best way to get by this is to educate the patients. And some people have done it by flyers. Others have done it on TV. In fact, in Brazil, they had TV ads. If your child looks like this, and they showed a picture of a kid with a white pupil. If your child looks like this, see an eye doctor. But I think the best way to change low, middle, and high income countries is to train people, train them about how to educate their population, send them back to their home, and get them up and running in their own oncology service. For example, right now we have doctors in training with us from India, from Taiwan, from Nigeria, from Afghanistan, from Thailand. They are from all over the world. Afghanistan has no ocular oncology. Every person that has a cancer of the eye has to go to Pakistan. And we have a doctor from Pakistan who's coming to join us. So we're trying as best we can to place these doctors in underserved countries so they can get ocular oncology to a level that simulates what we do here in the States. And how do I know that's going to work? Well, because I saw it happen in India. The quality of ocular oncology care in India is right on par with the US. And we've trained probably 20 doctors from India, and the quality of care is very high. They've established, each of those doctors has taken on more fellows, so they've trained fellows in their own country. So now they have, 40, 50 ocular oncologists that just take care of all of India. So you train one doctor, word gets out, you get a few more doctors, and they train their 5 fellows. It just balloons, and it's the way to educate that country on how to best manage these cancers. You can't learn by reading a paper. You can't learn if I go to Nigeria and I do a clinic for 1 week. That is not going to train the doctors. The doctors have to come to the States, spend a year, learn how to do things, and then go back and start their clinics. You can't put a dollar value on education. Education is why you're in medical school. It's why I'm at Wills Eye Hospital. It's your education gets you places.
So we talked about secondary prevention with the screening of the elderly population, the research to update those screening recommendations, and then also the training and the education is just so important. So thank you. Closing question is, we go into this career to help people, and it's also as important for physicians themselves to take care of their own wellness. Is there anything you do in particular to maintain your own well-being?
Yeah, boy, I love that question. So I'm basically a country girl in a cityfied situation in the middle of the Philadelphia metropolis. And when I go home each day, I go back to my farm and it grounds me. I feed our two dogs, I feed our cat, I feed our goats, I feed our chickens. And I love that because it makes me understand what really matters in this world. And my husband and I raised our kids on our farm. And I think they understood, they grew up loving nature. And I think each one of them is the same way. Um, so I keep myself kind of grounded. I try to keep my life as simple as possible. I try not to get myself overcommitted. And as far as nutrition goes, I live a very simple life. I eat only natural foods. I will never buy anything processed. I have to admit, the only processed food I might buy is bread. I don't make my own bread, but I make my own soups, and they're all from scratch. I just learned how to make soups this year. My daughter taught me how to make soups, and I love creating my own soups. And if I'm not eating soup, I enjoy like salmon and kale and vegetables. Usually I buy the frozen vegetables. I just think you get so much more nutrition. I mean, if I can get the fresh vegetables, I'll do that. I keep a garden, and just last night I went down and picked my tomatoes and a few of the snow peas that were left. I try to keep it as my life as basic as possible. And then on my way into work every day, I drink a big, I think it's like 20 ounces of water on the way in. I like to start my day really hydrated so that all systems are working. Once I get like 12 ounces of water, I physically feel so much better. Like I don't start my day with a cup of coffee. I start with 20 ounces of water and I feel really good. I usually have one cup of coffee a day.
Thank you for sharing. That painted
Yeah,
such a good picture.
yeah, and I do avoid desserts. I've never been a sweets person. I don't know. Sometimes the sweets just make me feel a little bit nauseated. So I have no craving for sweets. The sweetest
Mhm.
thing I eat is like watermelon.
Thank you for all the wisdom. I hope this helps medical students become doctors who stay grounded and are able to teach their patients these important topics. Dr. Shields, if you had to choose a walk-up song to the OR, what would yours be?
Well, I love Frank Sinatra. I would probably choose My Way. I did it
Classic.
my way because I don't think people quite understand what it's like to be an ocular oncologist and have to balance patient's life against saving their eye, against vision. We're constantly juggling those three things. And I am not allowed any wiggle room for error. So um, I do it my way. I do it the best way I can do it.
You do such incredible work. I've been lucky enough to see it in person, and it's truly incredible. And any last advice for medical students at all?
Yeah, my advice, medicine is such a noble profession. It's not about money. It's all about making a difference in someone's life. You know, it was funny because just yesterday I heard this quote from Tom Brokaw. I always liked him as a newsman. He says, "It's not hard to make a buck, but it is very difficult to make a difference in someone's life." But I think in the field of medicine, if you approach it with a clear view and a true desire to help your patients, you're going to make a difference in nearly every patient's life. So, and that's really all you want in this life, to make a difference. Everything else comes secondarily.
Thank you so much, Dr. Shields.
Thank you, Michelle. I really enjoyed it. You made me think outside the box a few times, and
Yeah.
that's what it's all about.